All right. Hi, everybody. This is Raj Kumar here, coming to you from my kitchen in Washington, D.C. Welcome all to the series of conversations that I have been doing. I'm President Editor-in-Chief of Devex, and having these conversations in this extraordinary moment of the COVID-19 pandemic with a number of different global leaders, people who have a unique perspective and a take that we all want to hear. So that is certainly the case today with Mark Dybul. Mark, thank you for taking some time to be with us. I think everybody in our community knows you well, knows your history well. You were one of the people who helped to found PEPFAR. You were its first leader, and you went on to be the executive director at the Global Fund. You're now co-directing a health and impact center at Georgetown University. You're thinking a lot about these issues, and you work a lot on these issues all over the world. So really eager to get your take today. Thanks for taking some time to be with us.
Great to be with you. Interesting choice to be in your kitchen.
It is, right? Yeah, this is the new world. Kitchen table conversation. We are having it. So maybe we just start. I got a whole bunch of questions that came in from social media for you, but maybe just give us the overall perspective that you've got. I mean, you've been in this field forever. The idea of a pandemic threat, a kind of an influenza-like virus, isn't really a new idea. It's something people have talked about for a long time in the global health world. Now it's here. How do you see it? How do you see the situation today?
Oh, it's a mess, with a few exceptions, and we can learn from those. Actually, there were countries that learned from past epidemics that they had in their regions, especially in Asia, where they had MERS, SARS, avian influenza. But yeah, as you said, people have been predicting this for a long time. This is the first time, and this will be the difference. We have pandemics. We have malaria, we have tuberculosis, we have HIV. Those are pandemics. We've had them for a long time, but they didn't really touch our borders or Europe's borders in large enough numbers. Of course, HIV does, but in a much smaller way than in many other parts of the world. So this is the first time we, as a country, are experiencing a pandemic. At least people who are alive. There have been them in the past, of course. So I think we're going to see a different type of response this time to the past ones. And my concern right now is we're not having a global conversation. Everyone's having a domestic conversation. This is not a domestic conversation. If it's not a global conversation, we're going to be right back where we are today in all likelihood in the fall.
Yeah, it seems like it's even more narrow than a domestic conversation. People are having a really local community, town and city conversation even. And, this is the big issue, I think, as I look at the mainstream narrative around this pandemic is it's a lot about what am I doing in my own community. But very soon, I think we're going to realize it also matters what's happening in the community next door, in the country next door, across the world. Maybe you can take us through what your thoughts are about that, because, we keep hearing different dates about when this thing might end and how it might go. But there's very little conversation about what's going to happen in the poorest countries in the world, in the places where you focused at PEPFAR and the Global Fund. How do you think this is going to go in places like sub-Saharan Africa?
Well, I mean, the answer is we don't really know. Right now, it's not surprising. It's local. Everyone's panicked, and because there's not a systematic federal response, it's not surprising. It is somewhat surprising. I was with the lieutenant governor of a very affected state 2 weeks ago. 3 weeks ago now, and I was shocked that she said the governors aren't talking to each other, the health commissioners aren't talking to each other. I mean, we've got to be connected. If we're going to realize it's global, my guess is it will be after it kind of comes down in our country and in other upper income countries. So right now we're just focused on their response, as they need to be. There are some people who can be thinking about the global response because they're not as involved in the domestic response. But my guess is it will be when it starts to come down in our world, we'll start paying attention. And, for those of you who didn't follow the 1918 pandemic of influenza, that was because of war. I mean, the movement was because of war. And it tracked troop movements. So it kind of ended in the spring of 1918 in Europe and the United States. A lot of people got infected, but very few died. But then it headed south, and following the troops to Algeria and Egypt and India, China. And then it was in the fall that it came roaring back and killed 50 million people over 2 waves that occurred. So it was actually a 3-wave epidemic. The first wave was mostly Europe, but then as it moved south, The following waves were in the fall. And those waves were deadly. We don't know why. We think it might have been mutation in the virus, a change in the virus, which can happen. That's why we have different influenza epidemics every year. And my hope is that we'll actually pay attention to that now, some people, but also as the epidemic starts. It probably won't go away, because people, as soon as movement starts, which we're seeing in China, especially if people are going to places in the south, where southern hemisphere, as they go into winter, which is a very important point perhaps, people will be traveling. So it's unlikely to go to zero, but it'll probably go to a very small imported case number, assuming we get our act together on testing and tracing. What it's going to look like in the southern hemisphere, in particular Africa, we don't know. There's still a lot unknown about the virus. Professor Wang from China has published that as they looked at the epidemic in China, they see a fairly significant, but it's too early to tell, difference between humid and hot environments versus dry and cold environments. That tends to be the pattern of other coronaviruses. Almost, I think everyone on this call knows there are thousands of coronaviruses. Every time we say I have a cold, 80% of the time it's a coronavirus. SARS, MERS, they were coronaviruses. This is just a unique coronavirus. But almost all other coronaviruses are in fact seasonal and very temperature sensitive. There's a big study, an important study that the National Science Foundation has funded to really look at and interrogate, is this truly a heat sensitive virus or not? The other thing about warm times is people aren't clustered together as much. And so it's not just the temperature and humidity in all likelihood, it's how we interact. Social distancing becomes much more common in warmer months. So we'll have to see. Those countries are heading into winter. Their winters tend not to be as bad as ours, but they have influenza epidemics. And so
you're thinking of South Africa and places in the very bottom of the southern hemisphere.
If you're in the once you go below the equator, you actually get pretty cold. I mean, it snows in Johannesburg every once in a while, every 10 years. But I mean, it can get cool, and certainly down in Cape Town. Same in Latin America. There are plenty of cold, dry places in Latin America. So we'll have to see. Right now, the virus is not taking off the way we see it in Europe, in Africa, or interestingly in other places that we thought it might.
Would we know that? I mean, with the lack of testing, do you feel confident that that is the case because we're not seeing? Because some people I talk to say, look, we're not able to treat respiratory illnesses of any kind in a lot of these countries because you just don't have the health systems to do it. So would we notice an uptick if coronavirus if this novel one were really taken off in these places? We
won't know for a little bit. Nearly all of the cases in Africa were imported to start with. They're trying very hard at case detection, and they have some systems in place we just don't have in the United States, actually, because they have community healthcare workers testing for fever, for malaria, or out delivering antiretrovirals. So they have some sentinel signaling that we don't even have, and that sentinel signaling was key and could have been in China if they'd actually followed the procedures they put in place, and was key in South Korea and in Singapore. It could be because of testing, but we'll have to see in the next couple of weeks, but you should start to see more people coming to the hospitals unable to breathe, right? So if you're not seeing an influx of people coming to the hospitals unable to breathe, then it would probably mean it's not spreading as quickly as and it's not just testing. But we don't know. We really don't know. It's possible. South Korea's done the most testing. Well, actually, Singapore has done more on a per capita basis. They estimate, it's basically 10 to 1. For every one you say you diagnose, there are 10 more people that have it. So that's an important number to be looking at. So that would mean Africa today probably has 60,000 cases rather than fewer than 6,000. It also helps understand death rates a lot better. Right now we're calculating death rates the only way we can, which is off actual cases. And it makes sense this would be a little more deadly this year because we have no immunity and we don't have a vaccine, but we'll have to see where all the death rates settle out. If you actually use that 10 to 1 calculation and do death rate calculations across the world, it's a lot lower than, the
It
numbers.
looks more like regular influenza in a sense, if you get there, right? Because it's
In terms of
between 1% and
yeah.
0.1, right?
Yeah, somewhere in between there. I mean, last year the U.S. was 0.13 for influenza, and 60,000 people died. It was a really bad year. This year is not so bad, but everyone's worried about young people, and we should be until we know more. But this year we've seen more deaths from influenza despite a better year in the 0 to 4, which we're not seeing, of course, with COVID, and 15 to 49 than we have in past years.
But just for people who might be listening to this and thinking, well, Mark is suggesting this is not going to be as significant because of those potential death rates being lower. Are you saying that? Or are you saying, look, this is actually the big one?
If we don't treat this like the big one, we're out of our minds. I mean, and the reason for that, at least in my view, which others might not share, is even if the death rate's lower than the 1% or 2% or 5%, if you look, let's just look at last year because we don't have all the numbers in this year. There are an estimated, because we can estimate now, 35 million cases of influenza. About 350,000 people were hospitalized and 60,000 died. And actually, if you look across time and history, including this year, of hospitalized patients with influenza, 6% died. The difference is that's spread across 5 to 7 months. And so you don't have the influx in the hospitals. If we had, 350,000 hospitalizations and 60,000 people dying in 4 to 6 weeks, they would completely overwhelm our system. So in part, this is when the peak is going to be all at once, and it's going to overwhelm our health system. It's also more infectious. Whatever the death rate is, and it's not going to be great. The death rate's going to be bad. But it potentially is worse because it's all packed into a couple of months rather than spread across a half a year, which is the true influenza season. But it's also more infectious, likely because we don't have any immunity and there's no partially effective vaccine. And so we're seeing the peak come together at a very high, all at once, and that's really dangerous. And then its mutation rate, if you look at the logarithm change in the mutations, and we know there are at least two subtypes, or we're not formally calling them subtypes but S and L. In the Faroe Islands, this is unpublished and really got to be validated. One seems potentially to be more infectious than the other, but we don't know yet. But it's mutating at a very rapid rate. It's almost reached the mutation rate in this short period that influenza did over the entire year of our influenza year. So if that mutation rate continues, the risk of a genetically mutated version of the same virus, COVID-19 to COVID-20, but off the same backbone, is pretty high. Especially if it goes south and continues, even as we reduce cases here in the U.S. So this is absolutely worth being as conscientious and responsive as we can be, because it's bad. And if the second wave is worse, we're in deep, deep trouble, and we just are not responding and don't have the systems to manage this.
There's several threads in that really fascinating comment I want to get into, but just quickly, just so I understand it, do you think this issue of mutation affects the timeline on vaccine development? The fact that you're seeing it mutate more rapidly.
It absolutely could. We don't know that yet. But as you know, influenza vaccines are not particularly effective. This year is a very good one. It's about 50%, but it can be as low as 10%. Because of the mutation rate and because it's a new virus every year. We don't know that that's going to be the case. And it could be like most flus, there's slight variation, but it doesn't jump like 1918. Usually the jumps are like when a new species jump, when there's a species jump, which is what COVID is, what SARS was, what MERS was, what avian influenza was. So, but if you have enough mutation and it continues on through the winter months in a significant way, it's possible that within the same effectively strains, you get a much more lethal version or a more infectious version. We don't know for sure, but that's kind of the hypothesis many people have around 1918.
Mm-hmm. And that'd be another reason for us to really ramp up efforts now, because we don't
Absolutely.
know what those second or third waves
We don't
could
know.
look like if they come.
We
I mean,
don't know.
part of what you were talking about there is the health systems being overwhelmed because of the onset of so many people showing up with the virus, with respiratory problems at the same time at the hospital. But what does that mean in the countries where health systems are really weak? I mean, some of the statistics I've seen are that, you know, the average American hospital might have more ICU beds than some entire countries in some of the global South contexts we're talking about. So if the health systems aren't there today, if people are, you know, breathing polluted cooking air inside their homes and they can't get, you know, they're getting respiratory illnesses, they can't get treated for those things anyway, or for pollution, you know, external air pollution, respiratory illnesses. Is there a big difference here with COVID-19? This is something I've heard from some of the global health professionals I've been speaking to. It's like,
it's absolutely completely different. It's completely different.
How's it going to look? Yeah.
It's complete. Well, again, we don't know because there are too many unknowns, because most low-income countries are in different climates. And then until we understand the climate piece, it's really hard to make projections about what it will look like. I also want to be clear. I'm not saying COVID is influenza. It's not. It's a different virus. It actually attacks in different ways. It directly attacks the lung tissue. And we don't have immunity. So we have to wait to see a lot of things, but it is not influenza. It's just, it is a coronavirus, and it could be a seasonal virus, but it is not influenza. So the answer to that is, we're not gonna have, and anytime soon, the response if these countries have these massive upticks, logarithmic upticks in infections with whatever percent, you know, 10% or whatever percent, needing hospitalization or significant care, and then quite a number needing hospitalization and respirators. If we get to that point, there's, you know, it's going to be, we're going to have to, so let's take it in two parts. The first part is to act now so it doesn't get that way. So what we need to be doing is working now to get to the countries massive numbers of test kits, working on, and the 5-minute kit is amazing because you don't need a laboratory for that. And then setting up the structures that can do what Singapore, South Africa, or South Korea and China then is doing now, which is case identification and control. Had we done that at the beginning, or had China done that? I mean, there's a great study that shows that if China actually had followed the system it put in place for sentinel surveillance, instead of having politicians come in and not want to report those data to Beijing because they don't want to look bad, had they actually not gotten in the way, they could have avoided up to 95% of the cases, because the system was in place to do the case detection. So if we can support the countries now with test kits, case detection, contact tracing, which actually PEPFAR and Global Fund support contact tracing now for HIV. You have to do it carefully, but you can do it. You can actually contain. And then if you contain, you don't have the need for the mass hospitalizations. And so right now, we need to be getting in there with the test kits, with the trainings, with the screenings. You know, South Korea, Singapore had checkpoints on the street to check people's temperatures. And then they had an algorithm. To be honest, this is what happened with Ebola. So the countries that succeeded, Mali had a couple cases, went away. Senegal never really had any cases. Cote d'Ivoire never had any cases because they responded by using the health infrastructure that was there with community healthcare workers to be monitoring, reporting, responding immediately, following people. You know, when you came across the border from Guinea and Mali, they knew exactly where you were. They knew what your temperature was, and if you got infection, they could case identify you and trace where you've gone. So if we support the countries to establish that kind of system, what South Korea, Singapore has, China had in place but didn't use, we do not have that system in the United States. Almost nowhere in Europe has that system. So if we can support them to put those things in place, then we don't have to worry, in a sense, as much about the explosion. If the explosion does occur, we need to be ready to do what we did in the end, which took way too long in Ebola. The US military should be involved. You know, the UK responded very strongly. France responded strongly for Guinea. So as you know, each each country took a country basically. In the case of the United States, and this is what we're doing now in the US, you can send the military in to put up a hospital in a day that can manage these things. So I think the first part of our response is immediate, which is put the system in place and support, and a lot of the groundwork is there. It's supporting the ministries and the connectivity that's necessary. And I would also add that I would be doing what we're not doing in the United States, add a connectivity layer between countries, not only within countries, take Kenya with all of its counties, but now be establishing a network across countries in a very systematic way. Bring in modeling, especially as we get information on, and we'll have it soon, on temperature sensitivity, humidity sensitivity, so you can actually model where the greatest risks are. You can model, there's a great organization called FRAME, BJ Pittman, you might know. They've already started modeling and have posted, they can model where people are concentrated, a lot of people in households, when a member of that household goes outside of the household for work, where people smoke, where people buy dish or soap to wash their hands. You can actually start modeling, and then if we have the temperature sensitivity data, then you can start modeling where the virus would go. And so if we support the countries to do that, support the region to be connected and learn from each other, if things expand, then maybe we can control. If we can't control, then we need to be ready to go in the way we did, a year in Ebola, with a massive response.
Can we just talk about that we? I mean, because what you're describing here, first of all, it sounds absolutely right to me. It sounds like music to my ears, although I think sitting here in Washington, D.C. and imagining the conversations that are actually happening in our government doesn't seem like those conversations are happening. It seems much more domestically oriented. But let's say they are happening. Who's the we? I mean, do you envision, you led PEPFAR, you were U.S. Global AIDS Coordinator. The current U.S. Global AIDS Coordinator is running the U.S. coronavirus response. You led Global Fund. Do you envision Global Fund, Gavi, PEPFAR? Is this a bilateral approach? Is this the multilateral development banks? Is it the health ministries in country that are kind of the point person and everyone is simply supporting their plan? How do we actually do this? Ebola was hard, but that was at least a small number of countries, relatively small populations. This is a much different situation. How do you see this actually rolling out, and who should be standing up and leading it?
So I think you have to divide it into pieces, right? So first of all, I think it's all. It'd be nice if the U.S. was showing a leadership role domestically as well as internationally. And there is a lot of great stuff happening here. Tony is breathtakingly, he's my mentor, and I'm not, thank God he stayed in this as long as he has. And Deb has had a lot of experience, not just domestically, but globally. She's a very global person, has been involved for 3 decades in all this, not just PEPFAR. So we have really amazing people. Bob Redfield at CDC, was running PEPFAR programs in Africa for years, not to mention the U.S. military's, entire health system. So we have really good people in place. They don't have the breathing room right now to be focused on these pieces, but others do. There are other people in the US government. There are parts of CDC that are not as engaged in the domestic response. There are people in USAID, and importantly, we have domestically and globally people who are involved in the Ebola response, who are in a different administration, who aren't directly involved with responding today. I think we can actually bring a group together, which I've argued for, to actually be planning and actually putting this in place. But the U.S. can't do this alone. So from a guidance, overarching technical perspective, WHO has to play a leadership role here in the regions, and they are. Tedros was a minister of health. He knows how ministries run. He's, I think, doing a great job trying to hold everything together. But they're not implementers, nor should they be. They're really to put and help support governments to put the practices and policies in place. So they can work with the bilaterals, and I would bring in at this point countries that are doing well, South Korea, Singapore, China, on their case detection methods, their approaches. CDC is quite expert at this in different parts of CDC, so that we can bring in the bilateral part with the multilateral part, and then others who have been involved directly, like the UK, France, that got into the actual implementation. Pull those people back. We all know who they are. We know who ran the Ebola response for those countries. We know who ran it for the countries themselves, including the countries that did well not just the 3 that didn't do well. Many of them aren't in office right now because there have been shifts in, political power in those countries as well. So there should be a system to pull everyone together to
kind
put
of a
together
global
the best
task
possible.
force, all the people who know this.
Yes, and we should be simulating in the United States and globally where this could go and how, model it out based on, as we get more data, we can actually use models to help us understand where it could go and how we should be responding, where we should be putting our resources with making sure we don't just follow the models because we can be off. And you can put together that kind of approach, but then both the bilaterals and multilaterals should be supporting the countries to put those systems in place in country, subnationally. Many countries have decentralized, just like the United States, so they're going to have to not just manage it federally. There's going to have to be bringing the governors together, bringing the county executives together, as we should be doing in the United States. And then you can have regional and across continent, in the case of Africa, approaches as well. It will be very important for people to learn from each other as they're responding to the epidemic. What we see over and over again is everyone's coming up with the same problems and they're going through the same processes. That's crazy, just like we're doing in our country. And then for supplies, you need an overarching monitoring of who has supplies, who doesn't, where's the virus going, how do we shift supplies. Our militaries do this really well. So, and so does the private sector. So that overarching group can't just be government, and in country, it shouldn't just be government. In the United States, in my view, the task force should not just be government, and certainly not federal government. You should be bringing in whatever your power structure is, in our case, states, mayors of big cities, counties, county organizations, the private sector, and importantly, communities. We have never responded effectively to pandemic without strong community engagement, whether it's behavior, like stay in your home, or it's finding people who are at risk and serving them. And that means getting supplies in. One thing we do know from Ebola and many other things, and we're already seeing this in Africa, is people are anxious about going to clinics, both healthcare providers and patients. And this is what we saw in Ebola, and we're seeing it already, which means we need to educate and get the protective equipment in for the healthcare workers. And we need to be educating the community, which means getting into the community. Don't stop going to clinic. There are a lot of people who need to get their antiretrovirals. There are a lot of people who, and now many countries are in their rainy seasons, although it's pretty variable. Adults will assume they have malaria if they get a fever. So how you get into the community and provide a different education framework, but we have the examples, how Senegal and Mali protected from having a problem with Ebola, how ultimately the 3 countries responded, how Lagos responded. And a lot of it was from infrastructure that existed, which was funded through PEPFAR, Global Fund, Gavi, other institutions, because there's a
polio eradication initiative. Yeah, a lot of this is what we normally think of as vertical funding, right? Disease-specific funding. But as Debbie Birx has complained to me in the past, and I've said that about PEPFAR, these programs really aren't vertical because they're building infrastructure along the way. I wonder what's your take about what Global Fund and PEPFAR should be doing? Because ARV is a great example. People need to go get their ARVs. That's not exactly social distancing. To go to the clinic, to travel maybe to get there. How do we manage the mitigation with the needs to do mass drug distribution in the case of NTDs or other global health priorities?
Yeah.
At a time when we want people separating, if you were back leading the Global Fund or leading PEPFAR, what would you do now? Would you pivot completely, or how do you manage the core functions of the agency while still reacting to the scale of this crisis?
Well, I think we have a good example from that, and that's what happened with Ebola. Now, that wasn't a pandemic, it wasn't everywhere, but it's a pretty good example of what can be done. You don't want to pivot entirely. First of all, there are other people with that expertise and work on it, but what we did in the countries and globally, but really we forced it down to the country, was what can we do to support the response in multiple ways. So part of it was, what community healthcare worker structures do we have? Where is the support for a health infrastructure? What can we do to bring in technical support? Because the same system that's necessary to identify people with COVID, you use for malaria. It's fever, right? And that was the case with Ebola as well, or for HIV. Then you need to really structure your system for the response and adjust it as necessary. I mean, one of the most remarkable things to me is that during the height of the epidemic in Liberia, they performed a national bed net campaign during the height of the epidemic, and they actually got national coverage of bed nets. So you have to work in country to figure out the issues you're raising, which are manageable if you bring in the education and talk with people. What we didn't do, because we didn't have the mandate, was to provide the superstructure that's necessary for all this. And ultimately, it was the three countries that came in and supported the governments for that response. But just to point out again, there are the people who led the response, Africans who led the response, and from the UK, the US, and France, they're all around. You can't pull people from China right now. They're a little bit busy, although we should be very careful about that in the United States, because if we don't get in there and support them, China just sent how many tons of equipment, and they're sending technical support. So, we either get in there now or China and Russia will.
I've heard this concern from other leaders who are telling me, look, the U.S. and the Western donor agencies are slow off the block here. We had an article about DFID recently, still figuring out their strategy. A lot of the big international foundations, the private foundations, they're still figuring out their strategy. Meanwhile, China is potentially going to come in and start building hospitals and start sending supplies. And, we could see their presence in a way that is really felt at the core of this crisis in a way that the Western donors, international organizations may not be if we don't move fast.
Absolutely. I mean, first of all, it's in our health interest to be engaged and make sure that things don't fall apart. But secondly, we have got to be in there, because if we're not, China and Russia are going to be. And it's not just China. Russia's gotten much more involved in global health recently. This is in our long-term interest too. Africa is doubling in size, population. They're the region with the second highest sustained economic growth. If you look historically, 11 of 15, and thanks to USGLC for a lot of these data, but 11 of 15 of our biggest trading partners are former countries where we had development resources going. We had a 63% in our agricultural exports to Africa over the past decade. 95% of consumers live outside of the United States. If we don't pay attention globally, we're going to be hurting economically and from a security perspective as well, because we're going to lose out. And China, in the last few years, we have been ceding our leadership, and China and Russia are stepping in. So, I mean,
a lot of the point in making that argument is that there's a concern, at least I've heard this, you tell me if you share it, that we're going through an economic recession as a result of this crisis. It could get really deep. It could be prolonged. What happens if governments in the U.S. and Europe pull back on their foreign aid commitments to decide this is not where we want to be funding, because we have such a crisis at home? Is that a legitimate concern? Do you see that? And then we had a related question that came in about, well, how are we going to pay for all this? So what's the funding mechanism? Do we have it today, or what would you recommend that leaders should be pushing for?
It's a very legitimate concern, and it depends on, this is where leadership comes in. And this is where, what's your perspective on the world and what does your future look like? We already were trending, as were many other places in the world this is a health issue, but we've been trending this way for a while. The world has been changing dramatically. We don't like change. And so people's instinct has been, we're going to look inward and backward and fearfully, or we can look outward and hopefully and look to the future and what do we want our future to look like? And so we've been trending in the isolationist direction for a while. And that's where leaders, elected leaders in our country and other places have been trending too. I hope this epidemic is a wake-up call that you can't do that economically, and look at where our economy, why is our economy growing? It's not because our 350 million people all of a sudden are producing everything and buying everything. We're not a self-contained economy. Our exports actually were growing significantly over our imports. You need a global economy if we're going to succeed. So, but there is a real risk of people saying, well, this is another excuse, but this, I hope, will help people see you can't, unless we close all of our borders indefinitely, stop all of our trade, we're going to have this problem for a long time. So, and then if you look at the cost, the cost of what I'm talking about, I haven't run the numbers, but I would bet that just the simple things we're talking about in terms of supporting countries to establish the systems that are necessary with the tests for case identification, contact tracing, quarantine is basically follow what South Korea and Singapore put in place, which we should have, which we don't. And then if it does get bad, to have the capacity, surge capacity, community and health system capacity to respond rapidly, to step up those activities, to do mass testing, not just, when in the initial outbreak phase, but doing mass testing, to do the hospital surges that we were able to do in Ebola, maybe, I don't know, $30 billion. I'm just guessing. Maximum, maybe 20. And if the rest of the world is pitching in too, instead of China just paying for everything, which is what's happening now. We just passed a $2 trillion package. And we're gonna have to do another one, and if this comes back in the fall because the epidemic is taking off in the South and surges back in a more deadly way, we're gonna need a $50 trillion package. Why wouldn't an investment of $20 to $30 billion not be a smart move right now? It's a
if you think of it as a percentage of, if you think of it as a percentage of ODA, official development assistance, foreign aid, and from the OECD countries, it's maybe a third increase or 25% increase.
Not much at all.
It's actually not that much if you think those numbers could really be sufficient.
I haven't run the numbers, but PEPFAR spends $4 billion, $5 billion a year basically. The global fund's at about $4. That's not in the big, if you're talking about an immediate response. And then it's ultimately about strengthening their primary healthcare systems, because that's what this all is, to prevent any other pandemic. This isn't going to be the last one. This is not going to be the last pandemic. And so if we don't have the systems in place globally as well as in our domestically, we're in deep trouble. The next pandemic could emerge out of Africa.
A key element of that system we got a question in about, which is health workforce.
Yep.
And this is supposed to be the year of the health workforce. Obviously now with this crisis, everybody's starting to realize how important the health workforce really is. And a lot of the countries we're talking about, sure, they have community health workers, which we don't have as much in the West, but what they don't have is a lot of the highly trained specialists and other roles. There's a big dearth of nurses, midwives, doctors in many places.
Yep.
How do we address the health workforce challenge, the paying health workforce, surging capacity around health workforce? What should we do on that?
I think we need to be clear on what's possible now and what's possible in the future and structure your healthcare system that way, which some countries are. To be honest, we've made a bit of a mess of it. Some of the work we're doing now, which I'm very hopeful about, is using human-centered design, really building community capacity, let them innovate. They'll come up with solutions to these problems we can't possibly, we should not be trying to figure out at a federal level or even at a governor's level how to manage a community. They'll come up with innovations. Then if we can share those, like how do you get people to clinic who need ARVs, or what system would we put in place to deliver ARVs? And how would you do that? How do you use the systems that are there to look for people with fever so you have early sentinel pickups? And what's the testing algorithm? Communities can come up with much better solutions than we're ever going to do at a national level. And that's the kind of work we're supporting, but then it has to be linked vertically so that the health system sees those innovations and can implement them. And actually in Eswatini, where we're working, the group is, and we don't go, so the work's continuing because it's all them. How that's structured, those community structures that have been built to respond to HIV can be used to respond to COVID is really exciting. But the workforce is, it's gonna be a long time till they have all the nurses and doctors. We don't have all the nurses and doctors we need. But the community systems can be very strong and the different cadres can be very strong. But we need to get more sensible about it. One of the things we learned in Eswatini, we actually supported, and this is all supported by the Gates Foundation, and now with some PEPFAR support. I'm actually a PEPFAR grantee now, oddly, in Cameroon and soon in Haiti. The community health, for the first time, we brought all the community healthcare worker groups together. The government, the country did. And it turned out there were community healthcare workers for malaria. There were community healthcare workers for HIV. There were basic community healthcare workers. Sometimes they were going to the same households the same day and they didn't even know it. So, you know, we can reconcile these things and have a much more systematic approach if everyone comes together, shares lessons. Now they actually were shifting to, all right, we don't need to do that anymore. And we should all be doing the same thing when we go. And they're actually changing their system around that. So those are the kinds of things we can do to have a rational approach to healthcare delivery in the countries. And it ultimately will get to a strong primary healthcare system that over time builds to something like we have, but that's going to take a while. But all those countries have, on paper anyway, systems that go from the community to the health post, to the clinic, to the tertiary hospital. Those referrals, they're just not always functional because they don't have the pieces in between. With modern technology, with the ability to build communities of practice across and throughout, vertically, horizontally and vertically through those systems, which is some of the work we're doing, it's amazing how quickly it can happen. And the innovations they have, they've solved, you know, a community has solved almost any delivery problem somewhere. If we would just learn from them and could learn and bring people together, we could go faster. So there's no question there's a healthcare crisis, healthcare worker crisis, but we can't replicate our model and we can set things up that function. And we know that because that's, you know, HIV is complicated. Let's go back 20 years. People in Africa possibly couldn't figure out how to do something as complicated as antiretroviral therapy, right? That was the prevailing view among public health care workers. There weren't enough doctors, there weren't enough nurses, it wasn't possible, couldn't be done. So why even try? Let's just work on prevention. But with the cadres that existed and by supporting them and by building the systems, you know, 18 million people in Africa on antiretrovirals, which no public health official 20 years ago, except for a few of us, thought was possible. It's quite possible. We have this prejudicial view of what can and can't be done in these environments. If you allow and unleash the creativity they have, they can solve these problems, and we should not be too prescriptive on it.
You know, you described how organizations might now share in a way they didn't before, you know, talk about their community health workers coming together and finding ways to share information. Some of the people I've been talking to are saying this pandemic could be that forcing mechanism that gets the whole industry to change the way it works. And I wonder what your thoughts are, kind of big picture, about if this is as significant as you're saying and as many people are saying, and you know, it lasts as long as we think it could. What are some of the long-term shifts that we might see, you know, around localization, you know, more money going to local organizations, to communities, to local professionals? What are some of those big shifts that you think might happen because we're going through this crisis?
Well, I hope the big shifts are related to that, that we will actually, and you know, Deb was doing this at PEPFAR around localization, which I know some people didn't like, but it's absolutely the right thing to do. It's a matter of timing, not. I understand why people object, and I understand the carefulness you need to have, especially around, say, antiretroviral therapy.
You're talking about Debbie Burks, who was moving PEPFAR funds more to local organizations, causing some controversy. Something we've reported on quite a bit. Which we did together. I mean, I ordered that when I was running PEPFAR, and she made it happen at CDC. Never happened at AID, so now she's trying to make it happen at AID. But those local innovations and really the technology has increased, the talent has increased. I mean, the talent pool in these countries now, largely because of the investments we've all made in the last 10 years and because of the responsiveness and leadership in the country, there's a lot of talented people around. And it's empowering them to actually be able, they are empowered. It's providing the platform for them to do what they're capable of doing in a much more systematic way. And to be honest, I think this needs to go beyond health, and I hope that is a shift that occurs. China's already done it. You know, I wrote about it in The Hill last week, but it's pretty brief. You know, in my view, we should be moving towards development plans to support countries on development plans, going from economic growth and development through agriculture, education,
job training and entrepreneurship training, and health. And what the World Bank has done with human capital, and the clear evidence that education and health drive economic growth. And ultimately, if we don't have economic growth, there's no stability, there's no chance of responding or building the systems people want to have for health. So development, if we can shift from individual things, not just be better at health, but be better at development, and really focus on how do we support countries to develop, those will become our great trading partners for the future. But that's the first piece to me, and we can lead by example by starting to do that on our own, but then also work internationally to make that happen. And then I think a much bigger change is necessary, and I've been promoting this for a decade. I'm hearing much more about it. Peter Piot, Julio Frank, and George Pumafi and I wrote about this, I don't know, 15 years ago, a long time ago, 10 years ago, but we were thinking, it took us 2 years to get it published. I think we need a Bretton Woods too. Bretton Woods, I'm sure everyone on the call knows, is in Vermont. It's a city. It's where the current development institutions were grown after World War II, and then we kept adding new ones, often with overlapping and competitive structures. These organizations are phenomenal. They do amazing work, but we do not have a 21st century development structure. And we're falling behind fast. And China's actually offering these packages. I met with African leaders, and they're basically saying we don't want to necessarily be doing this, but they offer us from economic growth and development through to agriculture, through to education, through to health, and you're not doing that. And we have the U.S. has the structures. We have those silos. We can put them together. We argued this forever, Rob Mosbacher and I, when we were in the Bush administration.
He was the head of OPIC at the time, right?
Yeah, head of OPIC at the time. And that actually, since we have a wonky group, that's what F was supposed to do. F was supposed to it wasn't supposed to, just account for where the money went. It was supposed to basically pull the PEPFAR model. All agencies come together around HIV. All agencies come together around development. And we work on development plans for a country and look at development, not just health or education or HIV or whatever. But globally, our organizations can't do that either. And so we need to remake our global organizations. Now that's really hard because it would mean closing, shifting, it'd be a massive change. Maybe this epidemic will show us why. I mean, this pandemic, and again, HIV exposed it, malaria exposed it, TB, this is the first time we are suffering from it. We worried about SARS and MERS, but those were or Ebola, but they were never, I was never really worried they were going to come big time to our country. This one is, and we'll probably, I think there's a pretty reasonable chance it's just going to be another seasonal flu. It's going to double our deaths. It's going to double our risk of another pandemic. We need to remake our global organizations. And until we remake our own approach, and we don't have much to stand on telling others they should change, but I think the US could work with others to create and host a Bretton Woods 2 to remake our development structures, to really focus on development and change this epidemic, SARS, MERS, Zika, Ebola, they've exposed how incapable our own domestic and international responses are for something like this. And we can keep doing the same thing and set up some, Band-Aids, or we can say, hey, it's time. We have enough data now that it's time to change.
I mean, that is a big idea, which even just a few weeks ago, months ago, people might have said it's a pipe dream, and we certainly had these discussions before and heard these ideas, but what you're presenting now is actually, there's maybe some potential in a moment like this. And lots of the leaders I'm talking to feel like the entire system could get scrambled depending on how significant this pandemic turns out to be. Yep. Publics are going to start asking questions in ways they haven't before. Maybe attention will come to these issues. It does feel like it is a moment that might be primed for change.
And you can explain to your constituency, if you're a member, why we need to start investing in a way we couldn't before. Before it was really, which I believe most Americans have, and data have shown this, people are willing to invest in development if you get results. And that's why PEPFAR and the President's Malaria Initiative and others, Global Fund, Gavi, that's why they do well, because they can prove impact and people can get behind that. Now you can have a conversation about, if we don't invest in their health systems, you could die. We've never been able to say that before with evidence that someone would say, now I know. So there is an opportunity, but it requires leadership, it requires vision, it requires, just really difficult politics. Just in our country, to shift from, individual programs to development plans, the way Congress appropriates radically has to change. The way the executive branch is structured radically need to change. Take that to the global level, and now you're multiplying the political complexity. So it requires leadership, paying attention, fighting the political fights, and being able to. It takes leadership.
And look, you've got leaders right now running a lot of these big international development institutions, health institutions, who have to deal with this crisis. They got to keep rolling on their core priorities, and they have to be thinking big about the future and what will this mean. I wonder what you think about Gavi. I mean, they've got to do a replenishment this year. You led a major historic one at the Global Fund before you gave over the reins there. Two of them, right?
Two of them, yeah.
Yeah, I mean, what do you think if you were in Gavi's shoes right now? As far as I know, they're still asking for the same amount, but they'll be the delivery system for any COVID-19 vaccine, I would imagine, much of the world. So what should they do?
They'll certainly play a significant role. I mean, and help get the price to something that's manageable and buy a lot. A lot of what Gavi does is buy vaccines in bulk, and they do country work too, but a lot of it is the purchasing and distribution to countries so the systems can deliver them. And that would be how you link Gavi with all the other systems that can, deliver in a country system. We all need to get behind the country system. So we'll see where all the money goes. I mean, we're not going to have a vaccine within, and Tony's been clear, for 12 to 18 months. And we don't even know if the current ones we have are going to be any more than, partially effective. Hopefully this will all actually accelerate a pan-influenza vaccine too, that will be looking for how do you manage all these mutations. And there are ways to do that. Caveat, I'm working with a biotech that I think actually has a awesome solution to that. But how that fits into the bigger system, I think is a question. You can't just buy vaccines. It can't just be a vaccine system. It has to be a health delivery system. But Gavi will have a key role. I think the Global Fund will have a key role. I think we've got a great set of leaders at global institutions, but there isn't the pressure and the required to overcome the bureaucratic inertia of change. And that's going to take, one thing I think we really need to stop doing is looking at the Global Fund, Gavi, the World Bank as donors, which is a terrible word anyway. They're not. They have to raise money. There are donors to them. They're mechanisms that donors with the money choose to use. And so we need the donors, the people are giving the money to the organizations, to be driving the change, and the stakeholders who are affected by the resources, the countries that ultimately spend more than they ever receive outside, because they're spending far more on their health systems in many ways than come externally. And I know people push back against that because on a financial basis, it's true. Some countries have a lot coming from externally, but all those people working, I mean, that's human capital. It might not be the money, but it's the human capital. It's all in the country. So if the people supporting externally and the in-country all kind of come together around a vision, which to me is leadership, and they're great leaders in Africa, what they're trying to do around healthcare financing through the African Union under President Kagame's championship role, and other things. I mean, they're ahead on a lot of things. They've got really talented leaders. They've got real opportunity and capacity, but we're going to have to change. We're going to have to change. And I think this, especially around a health crisis, to talk about, we're going to use this, pandemic when thousands of people are dying to change X, Y, or Z. I just think rather than that, we should be saying, what does this tell us about our domestic and global structures in country? I mean, domestically, every country, and global structures to support them. What does that tell us? And unfortunately, MERS and SARS and avian flu, Zika, didn't do it because they didn't get outside of regions and they didn't expose large parts of the world the way this is. This should be making us look and say, and go back and look and say, oh my God, if those had gotten out, what would have happened? And what are we going to do differently? And
I sure wish we would have asked those questions in advance of this global pandemic.
Which we should have, because they were all predicted. And countries did. South Korea did. Singapore did. China did. Had they just followed this, I mean, you've read the same stuff. Wuhan, a month before the outbreak, had just done a massive simulation of how to respond to a pandemic with 40,000 people participating. They just had, and they could have done it, but the politicians got in the way and wouldn't let the reports go up, which actually violated the process. So we know it's possible. They're there. All we have to do is replicate that and overcome the basically political and leadership barriers that are preventing us from doing it.
Well, look, coming from a lot of people, this would sound like, you know, an impossible dream, but you're somebody who set up some of the biggest global health institutions that exist today that have saved millions of lives. So thinking big goes with the territory for you. We're running out of time. So one last thing I want to get your take on, which is, as this is evolving, one of the things we're hearing from a lot of our members at Devex, who many of these people are on the front lines working on these issues every day, is, you know, what are some of the indicators that we should be looking at? You know, what are some things that you're looking at to try to see how this pandemic is evolving, you know, what it's going to mean from a health perspective, what it's going to mean from a political policy, you know, international organization perspective? What are some things we ought to be paying attention to?
So I think, you know, there's the epidemic itself that we need to pay attention to, but from a development perspective, I mean, if we are assuming, and I think with really good reason, and if you were betting, I would bet everything I have that this is going to become a seasonal thing that's going to recur. But it is possible, because it is a coronavirus, that it will disappear. I mean, that is a possibility. I think it's pretty much an infinitesimal possibility, but it's a possibility. If that happens and it doesn't come back, if it does what SARS and MERS did, which, you know, there's no reason to believe, because it's it's all over the world now, you know, 150 countries, 48 in Africa, probably all of them by the time this is done. It's fundamentally different. So what do you follow then? You follow what happens in our countries. You know, is this truly seasonal? And if so, what does that season look like? You look at the data that will be coming out on the temperature and humidity sensitivity, and then we follow what happens in countries with those temperature patterns, especially as they head into winter, to understand what's going, where it's going and how it's changing. So what happened with the pandemic in terms of where does it go over the next 5 months is hugely important. The data that we'll get on sensitivity, temperature sensitivity, and other factors that allow the virus to either be more infectious or more deadly and survive. The genetics of it, we have to be really tracing the genetics of it, which we have the capacity. I mean, the amount of genetic information that's already been generated is breathtaking. We've never been able to do that this rapidly with an infection, and we can follow, each country has their own kind of clusters, and, you know, we can follow that, and that can be studied in terms of what's the likelihood or what additional mutations are necessary. You can all do this in vitro in animal models to understand what genetic mutations just within COVID could lead to a more deadly or more infectious virus, and then track all of those things over time. But if we're just then what we need to track is how are we changing our systems so that countries can do what South Korea and Singapore did versus what the rest of the world and the United States has done, and what China has, you know, gotten back to. So really learning from those and bringing in the learnings which follow pretty much. I mean, the learnings from Ebola look very much like what you would have done in China, Singapore, South Korea. You know, how you react to an epidemic is the same. They're specific, and obviously Ebola is different because of the infectivity rate and the death rate. But that's the other thing we should be tracking. You know, are we putting these things in place, and are we responding and planning? Again, the people who are responding now need to focus there. They don't have the time or bandwidth. They're doing heroic work. But there are a lot of people who have had experience in this, who can be doing the thinking and creating papers. And then it's going to be for the people who are responding now to have the humility to say, I didn't have time, people have done work, I can take that and start from it. I don't have to start from square one and do all of our own stuff. And again, just within the US government, there are a lot of people who aren't in the immediate response who have expertise in the government. There are a lot of people in the state governments. There are a lot of people in the communities that can contribute. That's the same globally, and that's the same in the countries in Africa.
Look, time is of the essence, and I'm glad you're getting that message out there now, because this is the moment. There's probably a very brief window. As you say, it's in 48 countries in sub-Saharan Africa. It's spreading in the global south. If things are going to shift, they've got to shift now, immediately. Yeah. And as you say, there's not as much activity, not as much conversation happening in much of the world right now. A lot of the focus is in the global north. It's in the west, and we need to fix that and change that.
We need to fix that. And when I put that piece out on the Hill, I mean, there are people, when I asked them if I should put it, I was like, is it too early? Are people going to say this is just, you're just using the same old stuff and trying to, and I've already heard people say, oh, this can't affect HIV and we should just, but we've got to get over our own little self-interests, which is good because it saves a lot of lives, and think about the big picture. And now's the time to do it. If we wait, literally, it's just like the outbreak of this epidemic. If we wait 2 months to get this stuff started, we could be too late.
Well, thank you for sharing those thoughts with us, for helping us think big. It's been a fascinating hour to spend with you. I really appreciate it, Mark.
Always great seeing you and talking
with
Mark Dybul.
Thank you. All right. Thank you to everyone who's joined us, and continue to follow Devex for more coverage about what's happening on COVID-19. Thank you.